I'm back. Happy Wednesday afternoon, everyone. This is Ed Crow. Appreciate you coming on today. Today we're going to talk about complicated benefits with Medicare, original Medicare and Advantage plans. It's funny, when I was going over this information, these are questions I've had too, where you get questions from clients. So my hope today is that this will help you for your own knowledge, but also will help you kind of point prospects and clients in the right direction, because these scenarios come up quite a bit, and a lot of times I know in the past I'd kind of be at a loss for detailed knowledge as to what to tell them, and you would get the questions a lot. Other thing this will be useful for is this information is great to end a conversation that you want to get out of. So if you're talking to somebody at a social event, just bring this stuff up and they'll walk away pretty quickly, I would think. So hopefully you'll find this useful for a bunch of reasons. Okay, so a couple quick things. If you have any questions, send them into the webinar. I will answer them when I'm done. So we'll go through the slides about the usual here, probably about 25 minutes or so. I'll go through the slides. I will answer the questions at the end. We do record all these webinars, so we will record all of them. We will email you the recording, but also the easiest place to see this really is on YouTube, YouTube Crow and Associates. And for future reference as well, if you ever want to see one of our future webinars, we usually do them on Wednesdays or Thursdays at 1 o'clock. But if you just can't make that time, just register. If you just register, you'll get a copy of the recording, or just go on YouTube, because as soon as this is over, usually that same day, we'll put it up on YouTube. And you can see all our webinars there as well. All right, enough of that. So let's get started. So we're going to go over topics that come up when we're working with Medicare clients. Hospice, we're going to hit hospice, we're going to hit skilled nursing facilities and skilled nursing facility care. From some of the rules, discharge and readmittance, talk about the potential pitfall when you change plans while somebody's in a skilled nursing facility. A little bit about prior auth on Advantage plans, original Medicare inpatient benefit period versus MA benefit period. That's not as complicated, just more of a you should know in case you don't. And then we'll end up with the dandy, and that's diabetic supply and insulin coverage, which can be a little tricky when it comes to, setting expectations with clients as to how they get that, how it's covered. All right, so let's start with hospice. So basic rules with hospice. First of all, talk about, what it is and how you get it. So first of all, original Medicare only covers hospice with Medicare approved providers. That's a big one that comes up. People will get hospice care, but you got to check and make sure if you're on original Medicare, that's an approved hospice, a Medicare approved hospice provider. Hospice is for people with a life expectancy of 6 months or less. And with hospice, the way it works is you have benefit periods. So initially you start with 2 benefit periods of 90 days. But then if more time is needed, there's an unlimited amount of 60-day periods. In order to start the hospice process, that is a conversation with, obviously the client's family members, with the doctor, the hospice doctor, and the regular doctor. If they don't have a regular doctor, then just the hospice doctor, because they must certify the terminal illness. So that's how it initiates. You work with the regular doctor, or if not a hospice doctor, you certify that terminal illness, and then making you eligible for hospice coverage. You can actually search hospice providers, because that's a question I never knew the answer to, on Medicare.gov. I gave you the URL for that, but you can just go to Medicare.gov/care-compare. And you go on there, and that's a button right there to search for Medicare approved certified hospice providers. So once somebody's in a situation where hospice is needed, they would look up a facility, talk to the regular doctor. If there's no regular doctor, talk to the hospice doctor at that facility, and set up a plan of care with the hospice team there. And again, we have new people coming on. If you have any questions, I will answer them at the end. Just send them into the webinar, please. So one thing I think that's misunderstood a lot is original Medicare covers hospice, obviously, but it covers hospice even if somebody's enrolled in an Advantage plan. I kind of figured that out over the years, but I certainly didn't know for quite a while. But original Medicare takes over there even if they're enrolled in an Advantage plan. The Advantage plan, though, will continue, if they're in an Advantage plan, it will continue to cover services not related to that terminal illness. So, it's not that common, but other services that person may need that aren't related to that terminal illness would go right through the regular Advantage benefits, even though original Medicare is taking over the hospice piece. There is actually, if you look it up, there is a choice to have services outside of the terminal illness covered by either original Medicare or the Advantage plan. In my experience, it's just usually been one or the other. Quite frankly, I don't have experience with trying to mix and match coverage for the non-terminal illness by sometimes using original Medicare, sometimes using the Advantage plan. To me, that seems like a real recipe for confusion and disaster, but that is actually a choice. If a person's on original Medicare only, it will cover medical services not related to the terminal illness. So either way, if they're on original Medicare hospice, original Medicare is going to cover the hospice services, and original Medicare will cover the non-terminal illness related services. Same thing with the Advantage, but the difference is on the Advantage, original Medicare is going to take over and cover the hospice, and then the Advantage will still cover the non-terminal illness services. Anyway, for those on original Medicare, the non-related services will be subject to the original Medicare cost shares. So standard stuff, whatever Medicare's cost share is, while Medicare is covering all of hospice, there'll still be the standard cost shares for treatments not related to that terminal illness. Okay. That's the quick summary on hospice. Hopefully that answered some questions for those who weren't familiar with it. And we will move on to the next topic. So skilled nursing facility care, this one is really common in the business that we're in. So first of all, the definition of skilled nursing, I think it gets confused sometimes with nursing home and custodial care. And I do see there's questions coming in. Don't worry, I will definitely answer those for you at the end. Skilled nursing facility. So skilled nursing care is care provided by trained registered nurses in a medical setting under a doctor's supervision. So that's the definition of it. So in other words, the general theme here is skilled nursing is for someone that is recovering from an illness or injury. Nursing care, non-skilled, is focused on activities of daily living. You also hear the term custodial care a lot. You'll see why I'm setting the table for this, because ultimately this is the definition and the theme that leads to people getting kicked out of, discharged from the skilled nursing facility a lot earlier than they think. So just keep this in mind, the difference between the two, and obviously the way Medicare covers and doesn't cover the latter, also will lead to a motivation to stay in the skilled facility sometimes. So again, non-skilled, that's technically called custodial care, or a nursing home at that point, is separate from skilled nursing. As we all probably know, Medicare Part A covers skilled nursing. You need a qualifying inpatient hospital stay, that's 3 days, to qualify for skilled nursing on original Medicare. So if you're on original Medicare, A and B, and then have a supplement, let's say, you need a 3-day inpatient stay in order to qualify for skilled nursing. No, observation days do not count. So original Medicare, you need the 3 days, observation days don't count. Most Medicare Advantage plans waive this requirement. In fact, almost all of them will waive that 3-day inpatient requirement to receive skilled nursing. You're eligible for skilled nursing on original Medicare within 30 days of your hospital stay. So if you're inpatient for 3 days or 4 days or 5 days, then have 30 days. It's a 30-day qualifying period to receive skilled nursing care on original Medicare. Remember, MAPDs don't have that requirement. And again, something that comes up a lot is the skilled nursing facility has to be Medicare certified. That's something the family members need to check and make sure that the facility, if they want coverage for it, that the skilled nursing facility that the person is going in is Medicare certified. Okay, so skilled nursing facility care benefit period. So the coverage is per benefit period. Sometimes people mistakenly think that or you forget briefly and think that there's lifetime reserve days. That's only on inpatient on original Medicare. It has nothing to do with skilled nursing. So skilled nursing is per benefit period. So if you're in skilled nursing and the benefit periods are 100 days, if you're out of skilled nursing for 60 consecutive days, then it will start a new benefit period. And the benefit period, as we're used to and we've seen before, on original Medicare is days 1 through 20, no cost, 21 through 100 are 200 a day. And then as we know, after 100 days, you're not covered at all. And that is for that benefit period. If that person came out of skilled nursing for 60 consecutive days or more, they then would be eligible for another benefit period, but they would also need on original Medicare another inpatient stay to be eligible. The assessment. So the doctor and the skilled nursing facility staff create the assessment. And an assessment is, again, we'll wrap this up as to why it's important, but the assessment determines the kind of care they're going to receive, and also it has a determination in it in how long they're allowed to stay in the facility, the skilled nursing facility. The assessment starts the day the person arrives. So it starts the day they arrive, and it needs to be done, completed within 8 days of the stay. It is called a 5-day assessment. You hear that often, but the actual rule is 8 days. So assessment gets done, needs to be done once they go in, and then additional assessments must be done on days 14, 30, 60, and 90. I don't know about everybody on the phone, but I can't remember the last time, if ever, I had somebody who was allowed to stay in a skilled nursing facility for 90 days. But nonetheless, those are the dates where additional assessments need to be done. At the same time, they also will create a care plan, and that care plan determines the type of care they need and also goes along with the assessment to determine if they even qualify to stay in the skilled nursing facility. So the rough rule with this is you need 7 days a week of nursing or a combination of nursing and therapy, combined nursing and therapy 7 days a week, or therapy at least 5 days a week to qualify to stay in a skilled nursing facility. So somebody goes into skilled nursing, obviously if they're on an Advantage plan or on original Medicare, they're going to cover the skilled nursing facility. The rub here is obviously if they no longer qualify for skilled nursing and need then custodial care, that isn't covered under original Medicare or an Advantage plan. So there's a big incentive for multiple reasons for someone to want to stay in the skilled nursing facility at times. Maybe they really just need to stay because they are still getting better. Or in the other case, a lot of times, they want to stay because they want to avoid, or their family members want to avoid the cost of a nursing home. So as we talked about, coverage will end prior to 100 days if improvement is not being made, and that's where we get into improvement or restoration potential. So, somebody goes into skilled nursing, they think, okay, well, I can stay in here for 100 days, and obviously that's rarely the case. It comes down to improvement. The person must be showing continuous improvement in order to stay eligible for skilled nursing. Now, if you really get down to the specifics here, technically, improvement isn't one of the qualifications, although it's used so often. Person's in skilled nursing for 8 days, they're not showing improvement, and they're discharged out of the skilled nursing facility for not showing improvement. Now, that technically isn't one of the criteria, but ironically, it's used all the time on original Medicare and to a greater extent on Advantage plans. Anyway, when they are going to be discharged from the skilled nursing facility, they'll receive a written notice. They have to receive it in writing, and it's a notice of Medicare non-coverage. So that notice has to be provided, and that means the care is no longer medically necessary or has become custodial. In other words, they're not showing improvement, the condition isn't getting any better, and as a result, they're no longer qualified to stay in the skilled nursing facility. In other words, original Medicare won't pay for it. The Advantage plan doesn't want to pay for it. They have to get custodial care, which then won't be covered. Traditionally, original Medicare was not very tough on this requirement. So somebody went into skilled nursing on original Medicare, and Medicare wasn't very strict about showing improvement. So, but that's changing slowly now. If you look it up, Medicare is starting to tighten up on that. And in fact, I know from talking to a lot of agents, they've had this experience where people are on original Medicare and a sup, they go into skilled nursing, and after 8, 9, 10 days, suddenly they're being discharged. So where this was kind of easy in the past, it's suddenly, even on original Medicare, it's gotten tough. So in other words, if you no longer qualify, you're not showing improvement, you're going to get kicked out of the skilled nursing facility, but you will get your letter. So what if you need skilled nursing with the Medicare Advantage plan? It's the same basic rules and concepts. The only major differences are you don't need the 3-day hospital stay on a Medicare Advantage plan like you do on original Medicare. And on a Medicare Advantage plan, rather, after 20 days, which it's mandated, it has to be covered in full for the first 20, if they even make it in there that long without being discharged. But after 20 days, the cost share with the Advantage plan might be different than what original Medicare's is. So Medicare Advantage plans obviously are managed care, private insurance companies, and it's definitely been proven and shown that they have a lot more leeway when making the determination if someone is showing improvement. And of course, that leeway goes in the direction of getting them out of that skilled nursing facility quicker. So that's really can't be debated. People have longer stays, are allowed to stay in a skilled nursing facility longer on original Medicare than they are on an Advantage plan. Although that is changing now. Original Medicare is still easier, but that is definitely swinging in the direction of original Medicare is kind of starting to go the way of the Medicare Advantage plan. Anyway, on the Advantage plan, in more cases than not, being on an Advantage plan will lead to an earlier discharge from the skilled nursing facility versus somebody on original Medicare. Okay, so you'll run into this scenario quite a bit, or if you haven't, you will someday. You have a client, you had them on a Medicare Advantage plan, everything's going super well, they've saved a lot of money over the years, but then suddenly you get a call from them or from a family member saying such and such needs skilled nursing care now. And come to find out they are already receiving the skilled nursing care, and they're starting to approach their 20 days. Well, as a good agent, you might think to yourself, all right, they'll be better off now if I move them to a supplement in a Plan G or maybe a Plan F if they were Medicare eligible prior to 1/1/2020. Because obviously you put them on original Medicare, it'd be easier for them to stay. Put them in a Plan F or G, it'll be covered in full versus the cost share on the Advantage plan. But you got to be really careful with this one as an agent. You're trying to do something that is the right thing for them, but it might backfire on you badly. I've personally had this happen to me. So that person's on the Advantage, use some kind of special election perhaps and move them back to original Medicare and a supplement while they're in the facility. Keep a couple things in mind. The Advantage plan doesn't require the 3-day hospital stay for skilled nursing. So in the middle of that skilled nursing stay, you move them to original Medicare. They didn't have the 3-day hospital stay. Original Medicare may not pay for that because they didn't qualify. The other one that's really tricky is and just to go back for a minute, because obviously the Advantage plan doesn't require the 3-day stay, original Medicare does. The other one that's really tricky is maybe they did have a 3-day inpatient stay on the Medicare Advantage plan, but then you move them to original Medicare and a supplement. Some skilled nursing facilities find a way to get around this, however, others do not. Those days in the hospital on the Advantage plan might not count in Medicare's eyes because they were on a managed care plan. Medicare wasn't primary. Point of this is this can get really messy for you as the agent. You're trying to do the right thing and switch them. However, if they run into trouble where original Medicare won't cover because they didn't have the 3-day stay or because they're not counting the 3-day or more stay they had on the Advantage plan, that can put you in a really bad spot. So I hate to say this, but my advice is if somebody's in a skilled nursing facility on an Advantage plan, I wouldn't switch them while they're in. That's just my advice. People may differ with me, but I personally had that go really wrong on me. It was the second scenario. They had the hospital stay. I was smart enough to check that. But that original Medicare, for some reason, didn't count the hospital stay on the Advantage plan. And of course, as we mentioned, Advantage plans and original Medicare do not cover long-term care or custodial care. So when they're out of the skilled nursing facility, then they're staring at a much bigger number that they're going to have to pay. Okay, let's talk about prior authorization on Advantage plans. So first of all, what is prior authorization? Well, that's where somebody goes to a provider, whether it be hospital, doctor, whatever it might be, and they're on a managed care plan, so they have to receive approval prior to getting certain medical services. 99% of MA plans out there require prior auth for at least some services. I've never run into that 1%, that one company that doesn't. Pretty much from what I've seen, they all require it, but it does say there are a few that don't. So original Medicare versus Advantage plan. Original Medicare has not historically used prior auth, but they've started to do that recently in the last few years. So they started to introduce it, and they're also currently, as we speak, reevaluating their stance on prior auth. And by reevaluating, I mean thinking about increasing it, not reducing it. So they've introduced some concepts of prior auth for a few things, and they're now having discussions about increasing that potentially a great deal. So they're starting to require prior auth for some services like home health care and certain outpatient surgical procedures. But my guess is that's going to increase, and they're going to require prior auth on a lot more down the road. More prior auth stuff. So what are common services requiring prior auth on Advantage plans? Keep in mind, every plan is different. You really got to look at the evidence of coverage to figure out what services an Advantage plan requires prior authorization on, if you really want to see a comprehensive list. So this is general for most plans, not all. Most plans require prior auth on any durable medical equipment that's $500 or more, home health care, hospice. Inpatient admission doesn't really count. That's a notification only. They don't need the prior auth, obviously, to go inpatient, but the plan has to be notified or that claim can be denied. Usually that's handled by the specialist or the primary or whoever's coordinating that inpatient stay or the hospital themselves. But I've had situations where that notification has not been provided, and that will create a huge mess then for the patient. Part B medications usually require prior auth. Behavioral health services almost always do. Certain orthopedic surgeries, pain management almost always. Transplants always. Some radiology, sleep apnea studies. That's a list of some of the things. There's more. Again, if you look at the evidence of coverage for a plan, you'll see that they'll have a comprehensive list of what they require it for in the evidence of coverage. So carriers list services requiring prior auth in the evidence of coverage. As I mentioned, providers need to request the prior authorization. That comes up a lot. The provider is the one who initiates the prior auth process. It's interesting because a lot of times providers won't do that. Not a lot, but sometimes. They won't get the prior auth, but ultimately, even though it's really the provider is the one in place, in the position to request it, the patient really isn't in a position to request prior auth. It ultimately is the patient's responsibility. But with most doctors, most hospitals, they understand this process. However, if they don't, that's something that can be a problem. So when you're talking to clients, I would just say to them, listen, your doctor or the hospital or whoever the provider is handles this, but you might want to double check with them to make sure they're getting it. The doctor or the provider also is the one who requests exceptions for denied authorizations. And of course, there's an appeal process. There's theories out there that insurance companies deny X amount of authorization requests, just kind of like a mail-in rebate. Just make it hard and hope it'll go away, or maybe a certain percentage won't follow up. It's hard to find statistics on that, but there is an appeal process and multiple levels of it as well. There's a new CMS proposal out there right now that says they're proposing that they will put time frames on prior auth requirements. As it stands today, we tend to think it's 14 days, but that's really not in writing anywhere. So there's nothing really enforcing that either. So somebody can wait a long time for a prior auth. Usually they're pretty quick about it, but their CMS is looking to put a specific time frame in place, and that proposal is that urgent decision prior auths are within 72 hours, and then non-urgent needs are within 7 calendar days. That's for non-urgent requests. Okay, let's do an easier topic now. Just something to be aware of. Many of you probably are, but for those who aren't, the original Medicare benefit period. It's not confusing, but good to know. So the original Medicare inpatient benefit period is 60 days. It starts when you're admitted. So a person's admitted, they get the coverage that they have on original Medicare for inpatient hospitalization. That benefit period ends when there has not been care, so they haven't been in the hospital for 60 days consecutively. So when somebody goes in the hospital on original Medicare, they pay their deductible of $1,600. Now, if they're then released 10 days or 5 days later, and they go back in before they're out for 60 days, they're still in the same benefit period, and they don't pay that $1,600 again. You only pay it once per benefit period. And mistakenly, we tend to think Advantage plans work the same way, and they don't. So Advantage plans don't have a 60-day benefit period for inpatient stays. So on the original Medicare example, I went in for 5 days, paid my $1,600. I come out for 2 weeks. I go back in. I don't have a new deductible, so I'm still in the same benefit period. Advantage plan, obviously not. I go in for, let's say it's $250 a day for 5 days. I go in for 8 days. I come out of the hospital then for a week, and I go back in. Well, I've got a new set of copays then to meet again on the inpatient stay. There is no 60-day benefit or grace period, so to speak. Okay, we get to the topic of diabetic supply coverage. So a lot of us have probably run into this one. It gets tricky depending on, are they on Advantage versus original Medicare versus a PDP? And I think the confusion here really is how original Medicare, because the Advantage plans really pretty much follow suit on this, but how original Medicare covers devices in supplies used with monitoring devices versus insulin in the supplies needed to inject or take that insulin. Two different things. They kind of seem like the same, but they're not. So original Medicare for glucose monitors, okay, and supplies used with them, such as test strips, lancets, and devices, and that's for the monitoring. That falls under Part B. What gets tricky about this is when it comes to the actual insulin, so the insulin itself, and then the things used, the supplies used for delivering that insulin, syringes, needles, swabs, gauze, inhaled insulin devices, those fall under Part D. So that's the difference. I always personally confuse that. Insulin pumps and the insulin the pump uses falls under B. So if they're getting insulin through a pump, the pump and the insulin is a B benefit, and it falls under Part B under durable medical equipment. Let's hit the details of this. So Part B covers blood sugar, glucose, self-testing equipment and supplies. So the monitors, the supplies, all is DME under Part B. So blood sugar monitors, blood sugar test strips, lancet devices, and lancets are covered under B. B also covers the same list above for people with or without diabetes. So if they need to monitor these things and don't have diabetes, it's covered under B. Or if they do have diabetes and are monitoring these things, it's covered under B. The difference about having diabetes or not, or using insulin or not, I should say, is if you use insulin, you get up to 300 test strips and 300 lancets every 3 months. Versus if you're using this monitoring but you don't take insulin, then you get 100 test strips and 100 lancets every 3 months. So that's the difference. Are you taking insulin or not? And that determines original Medicare and how many test strips and lancets they'll pay for. Part B of Medicare also covers therapeutic continuous glucose monitors and related supplies. Keep in mind on all these things, you need a script from the doctor. And the big question is how often? Well, every 12 months. And usually the supplies, the medical equipment and supplies can be picked up at the pharmacy or from a medical equipment supplier. All right, insulin pumps. So Part B covers insulin pumps worn outside the body, including the insulin for the people with diabetes. So the pump and the insulin. Part D is for insulin. So Part D covers injectable insulin not used with a pump or an inhaler, because that falls under the D benefit. So it's insulin not part of a pump, not part of an inhaler. That's covered under Part D. And then also, and again, this is what confuses me sometimes, I think, is the supplies used to inject that insulin. So syringes, whether they be a syringe, a pen, which you see more often than not now, needles, swabs, gauze, fall under the D benefit because they're used for the actual insulin itself. So how do Advantage plans handle this? Well, very similar, actually. The Advantage plan, the blood glucose monitors, test strips, Lancet devices, and Lancets, they go under the medical benefit. Now, this depends on the company. It could be under DME in some cases, and that might be a 20% cost share. Or there's a number of companies out there that specifically say we cover these specific things at zero copay, zero cost. So that could range anywhere from 0 to a max of 20% as a DME coverage, depending on the plan you're in. Insulin pumps go through DME. Insulin itself goes through Part D, unless that insulin was part of the insulin pump. And again, that insulin pump going through the DME benefit depends on the company. Some companies will cover certain brands at no cost. But if they don't say anything about it, then it's just going to get under DME, and that's a 20% cost share. So insulin pens, syringes, and needles go through the Part D benefit. Keep in mind with this, you got to use the approved vendors and manufacturers, like just to say a company, Aetna. They cover certain brands, certain types, versus United might cover different brands and different types. Your client's got to call customer service and make sure, or get a list and make sure that they're getting a brand or manufacturer that is covered by that company. Okay, enough about insulin. And again, those who are on, I'll answer your questions. I know I'm running a little longer than normal today. But again, it's a little more of a specific topic. Remember the Insulin Saver program. So that caps certain insulins into $35 copay. The insulins that it caps, there is no deductible or donut hole. And that is effective currently. So when you run this on a Connector, a Sunfire, it will reflect that $35 copay. And it'll also reflect that it's not subject to the deductible, not subject to the donut hole. The carriers themselves have until the end of March 2023 to update their system. So this is effective as of January, but they've been given some leeway here to try to, catch up with this and update it and cap those insulins at $35. So if your client is charged more, the rule says, I'll believe it when I see it, but the rule says that they have to be reimbursed within 30 days. So they should have had a $35 cap on their copay. They didn't get it because the company has until the end of March to reflect that. They're supposed to be reimbursed within 30 days. Keep in mind the Saver program does not cover all insulin. There is a list. We have that. We can email it out to you. There's an approved list of insulin that Medicare has put out there. And then the other big thing is, prior to this being made official by the government, the past Insulin Saver program under the old administration, that covered some insulins. Not every plan participated with it. So here it's more official. However, one of the negatives is that old program covered some of those expensive hybrid sort of insulin drugs. Those are not covered any longer. So they do not make that $35 list. And I said it doesn't cover the new kind of insulin drugs like Jardiance, Victoza, Januvia, Trulicity, Ozempic, and other drugs like that. They are not on that $35 list. We have the list we can send you. The list is specific to the medication, specific to the dosage. Wow, there we go. That was a lot of talking. We're done. Let me see if we have questions. I would assume I have a couple. Somebody said maybe get these slides. Yes, certainly. If we won't send that out in our just batch that we send to everybody. So if you don't mind, just email us or call us. And just to remind me, we'll shoot those slides out to you. Original Medicare also covers hospice if done at home. Yes, good point. They do. Original Medicare will cover hospice if done at home. I hear either the admission day or the discharge day don't count. Correct. I didn't mention that. That is a good point. So to make the complete thought here, I hear the admission day or the discharge day don't count as one of the 3 days. That is correct. But it depends on the admission day of when you go in. That's really specific. So it could count, but usually doesn't. Let's see. Comment was made that some Advantage plans are charging a small copay for the first 20 days now. I was not familiar with that, that's being done. I haven't seen that personally, but I will, something that's good to know. I just know the ones I've looked at. I've looked at a lot of them in a lot of states. I haven't noticed that yet, but I'm sure maybe there's some plans out there that have that. Okay, so somebody asked a question, how does the benefit work when a person is in a skilled nursing facility on an MAPD plan and they switch to another MAPD while they're still in the skilled nursing facility? Who pays the bill? Well, okay, so it just goes by effective date. So if they switch to the new plan, I know what you're saying, will the bill carry over for the old plan? It's when they switch to the new plan is supposed to cover. I would not recommend, however, just to save you some trouble here, I would not recommend switching somebody's Advantage plan while they're receiving skilled nursing care. I think you're asking for a lot of trouble, headaches, I should say, if you do that. Somebody said this from personal experience, they got their ortho surgery approved within a couple hours. Okay, good point there, and that's referring to a Medicare Advantage plan. Let's see, what's my next question? How does, let's see. Does the 60-day hospital benefit period cover only if admitted for the same condition or any condition? Any condition on original Medicare. Let's see. Let's see, somebody said, I think they need 3 overnights. At that mark, I think the hospital has to change from observation to inpatient. It does not actually, that's what I thought too. I looked that up. It doesn't go by the overnights. They don't have to be in for 3 full nights. It is really specific. I should have gotten more information on that. But it doesn't necessarily have to be 3 nights. I did look that up a little bit prior to doing this webinar. Let's see if we have any other questions. It looks like that's all we have. All right, so there's no other questions. I appreciate everybody coming on. Kind of heavy content today. So thank you. We will send out the recording to everybody. Go on YouTube if you want to see any of our old recorded webinars, even the new one. This one will be put up there this afternoon. So youtube.com, Crow & Associates. We will email out the recording of the webinar, and we will also send out that medication list for insulin if you have not seen it. Other than that, hope to see you next week on a new webinar. We'll probably do something a little more, well, a little easier for me, I hope, too. But again, anybody who has any suggestions for topics, please send them in. We're always open to suggestions of future webinar topics. All right, well, thanks. Have a great day.